Did you know that every disease treatment available to us today was at one time approved through a clinical trial? Yet only 37% of Americans say they would participate in one. There is no doubt that clinical trials have saved countless lives. So why is the perception of them so low? Today, the importance of setting up clinical trials in the communities who need it most, and one mother's fight to create awareness of Lynch syndrome. I'm Olga Villaverde. Access Health starts right now. PAD affects more than 8 million people in the United States. Currently, there are no viable treatments that can repair damage to the arteries and save a patient's lower limbs from possible amputation. Sadly, many of those with PAD do get amputations, or they die from complications from the disease. PAD disproportionately affects the African American, Hispanic, and Native American communities, the very people who are least likely to know what PAD is or get the right treatment. Over 1,400 miles away in Cleveland, Dr. Kendi White-Solaru and her colleague, Dr. Mehdi Shishambor, are tackling this challenge through education and awareness.
I don't think that the majority of people, both patients and honestly providers, a lot of people are not as familiar with peripheral artery disease as with some of the other major cardiovascular conditions that we think about, like a heart attack or a stroke, for example. Only 1 in 5 Americans know what peripheral artery disease is and can describe it when asked. Educating my patients about what peripheral artery disease is, especially if you have any of the risk factors, is crucial because it's most important that you get checked out early so we can prevent progression of disease. Peripheral artery disease, we now know, has one of the highest racial disparities. African Americans have the highest rates of hypertension in the world, and hypertension we know is closely associated with peripheral artery disease. Diabetes affects Hispanic Americans as well as African Americans and Native Americans disproportionately. Having peripheral artery disease itself comes with serious consequences, the biggest of which would be amputation. And that's something that we try to avoid at all costs because it has a major impact on quality of life. We know that. And not just that, having an amputation significantly increases your risk of mortality. So we need to save limbs and save lives.
Unfortunately, I think many folks out there, many of our patients, they think amputation is inevitable. That, my grandpa had amputation, my grandma had amputation, so eventually you have diabetes and you lose your leg or you lose part of your foot. That is not the fact. That is a myth. And we need to educate our patients. I always say, please get a second, a third, and even a fourth opinion, because amputation should never be the answer until all options have been exhausted. I think we can really impact the outcome of our PAD patients by a number of initiatives: advocacy, education, research, and innovation. As you know, there's been a significant amount of innovation and research in our field. I'm excited that we are conducting a number of trials that are going to change the outcome of patients with PAD and CLI. And I think if we take a collective, multidimensional approach, we can really put a dent into the bad outcomes associated with PAD and CLI.
It's great that if you have the opportunity to participate in a study that can increase our knowledge and awareness about peripheral artery disease, that is what I encourage all my patients to do.
There have been clinical trials in the past that have mistreated the African American community, which could be a contributing factor to low participation rates. Medical experts are working together to rebuild trust in these communities, but it isn't that simple.
There are many patients that are hesitant or skeptical about enrolling into clinical trials or considering clinical trial. Obviously, I think as a field, we have not done a good job of, and because of some of the past experiences, there is reservation. And the folks that are hesitant to enroll into these trials are typically from those communities that have CLI, that have PAD. We really need to make an effort to educate. We need to build trust with our communities. And my ask would be that for patients that have PAD and CLI, to please consider getting enrolled, because that's the only way we can close the disparity gap. That's the only way we can change this field to be able to make an impact and save limbs.
Coming up, how Abbott is reaching out to add diversity and inclusion to their clinical trials. Antonio is going in for a checkup after having an experimental device implanted in his leg. He is participating in the Life BTK trial. It's a clinical trial testing out a new device designed by Abbott to treat peripheral artery disease, PAD for short, which blocks blood from flowing freely in your legs. Dr. Lisa Ochoa runs the SAVE Clinic in San Antonio, Texas. She is Antonio's vascular surgeon and recommended that he participate in the clinical trial. Antonio is a perfect example of many other patients living in underserved communities.
I met Antonio Acosta when he was referred to me from a local managed care group, and he had had an ulcer on his great toe. He was clearly surprised to hear that he had peripheral arterial disease or bad circulation. And so when I told him about peripheral arterial disease and him having diabetes, his immediate fear was a concern for amputation. I began to realize that he would be a great candidate for this trial and the stereotypical patient that truly needs better care for peripheral arterial disease.
Ironically, the people at the greatest risk of amputation or death are the same people least likely to participate in clinical trials.
I believe the reason some patients are excluded in clinical trials is simple access to care. Most clinical trials occur in large academic centers. They're usually in urban areas. My patients don't have access to those areas of town. These underserved communities also have lack of access of transportation. Not only can they not get to the doctor that has clinical trials like in a big medical center, but even to get to the routine care, whether it's the increased surveys that they have to go through, the pictures, the physical exams, the studies. And so that is a challenge for my patients if they don't have the transportation or the means to be able to provide the time and energy for all that goes into a clinical trial.
Historically, the percentage of minorities who participate in clinical trials has been significantly lower than their respective populations. And yet, conversely, the incidence of certain diseases in those same racial populations is disproportionately higher.
There's many components to the disparate outcomes we have in our Hispanic population who end up with diabetic amputations. And in San Antonio, north to south, our highest zip codes have 3 times that of the state. And it's when I began to learn about the history of San Antonio and segregation in San Antonio, and the fact that these neighborhoods, these zip codes with the highest diabetic amputation rates, actually were red line neighborhoods back in the 1930s, where infrastructure into those communities was not accessible to them. The reason I created the SAVE Clinic was really to focus on decreasing diabetic amputations in the highest risk areas in San Antonio and the zip codes with the highest diabetic amputation rates. And so my main office is in the heart of South San Antonio, where we have some high diabetic amputation rates, and my clinics are there as well. I believe that practitioners like myself can increase diversity in clinical trials by taking on that challenge of opening up our patient populations to these trials. When we have the support of industry and we clearly have the patient population, I think this is how we actually increase diversity in clinical trials. We have to go out and find those physicians that serve these underserved communities who really are the ones that are going to benefit from progress in this research.
Abbott is a leader in the world of clinical trials and is trying to address some of those practical barriers that prevent patients from enrolling. The company recently launched clinical research to evaluate a potential therapy for PAD.
The BTK is an investigational device that is used to reestablish the flow of blood, and eventually it resorbs like a resorbable suture.
One of Abbott's goals is to bring more inclusivity to racial and ethnic groups that have long been underrepresented in these critically important clinical research studies.
It is important for us, and we've decided to take decisive action in this case, in this trial for PAD, which we know affects these populations substantially, to make the trial reflective of the population, to make sure that we understand how the process works, how to recruit these patients, how to put them in the trial, how to make them feel comfortable belonging to a trial, and to see themselves represented in the results. We are reaching out to physicians who come from these communities, who themselves are part of the community and have the trust of their patients in that community. We are providing these centers the training, the mentoring, and the necessary resources that they need to effectively participate in the trial.
Abbott hopes the Life BTK trial becomes a model for future trials. They want diversity and inclusion to be a standard component of all clinical trials. We encourage you to have an open conversation with your doctor or visit life-btk.com. Lynch syndrome is an inherited condition that increases your risk of colon cancer, endometrial cancer, and several other cancers. Erica Vitrini joins us on location today with more.
Their genes carry inherited mutations through generations of family members, bringing with them a significantly higher risk of a cancer diagnosis. Lynch syndrome is an inherited genetic mutation that is associated with an increased risk of endometrial, gastric, and ovarian cancers. It is also the #1 cause of inherited colorectal cancer. Our story begins here. Take a look.
When Jacqueline was 15, she had a lot of pain in her stomach and bleeding when she went to the bathroom. The doctor said, it can't be cancer because you don't get colon cancer at this age. 4 years had gone by and many doctor visits and still no answers. Jacqueline was losing precious time.
I got a call saying, you need to come here right now.
He knew that it was cancer. His exact words were, she has cancer and it's big.
Asking my mom, is she gonna be okay? And my mom not being able to know.
She was in such physical pain.
The genetic counselor said I'd be surprised if she didn't test positive.
For one doctor to miss it, you might understand. This was several doctors, and all of them combined missed it completely.
You talk to 10 different people and ask them about Lynch syndrome, you'd get a 0. If you went to 10 different doctors, you might find that 4 or 5 of them don't know.
And that means that over 1 million people have Lynch syndrome, and 95% of those people are unaware of it.
Often referred to as a silent killer, Lynch syndrome is one of the most common hereditary cancer syndromes. However, it is surprisingly unknown among families and physicians alike. Since there are no specific symptoms associated with Lynch syndrome, the result is often too many people getting diagnosed at a later stage when it is harder to treat.
Jacqueline died from colorectal cancer. You know, it really was a struggle for us to get the right answers. And, you know, Jacqueline went through a lot. It took 4 years for her to be properly diagnosed with cancer. And by that time, it was quite advanced. Actually, the doctor that did the colonoscopy said, I don't even have to wait for the biopsy report to come back. I know it's cancer. And while she was going through treatment for cancer, her oncologist suspected that she might have Lynch syndrome, actually because of her age. So that's how we found out. We talked to a genetic counselor and discussed our family history. One of the things that was tough for us is that there wasn't a lot of cancer in our family history. Really, the only person in our family that had colorectal cancer was her grandfather. She actually said to us, even though your family history doesn't show that she might have Lynch syndrome, I'd be very surprised if she didn't test positive. And in fact, she did. And then her dad was tested and he was positive too. Had we known it was in our genes, or had her doctor known there was something called Lynch syndrome, I'm sure her story would have been different.
Following the loss of their daughter, Joan and Alan Rush formed the Jacqueline Rush Foundation with the mission to save lives by increasing awareness and research of Lynch syndrome, the underlying cause of Jacqueline's cancer.
One of the things that spurred her dad and I to start the Jacqueline Rush Foundation was really the fact that all of our doctors had no clue what Lynch syndrome was. I think it was really surprising to us and actually made me kind of angry that the medical community didn't know about Lynch syndrome. So in 2015, after she passed away, we knew we had to do something to get this word out. I didn't want what happened to Jacqueline to happen to other people.
Hereditary risk greatly increases the risk for cancer to develop, and in the case of those who have tested positive for Lynch syndrome, those families have dramatically increased risks for cancer versus the general population. Families with Lynch syndrome have a greater than 80% risk of developing colorectal cancer, and for women with Lynch syndrome, a more than 60% risk of developing endometrial cancer. Knowing if you have Lynch syndrome can provide your doctor with important information for implementing screening and surveillance programs.
When you know you have Lynch syndrome, you can do many things that will help you greatly reduce your risk for getting cancer. You can do screening more frequently at a younger age. And after you have a family, you can consider risk-reducing surgeries. If you could do something that would prevent you from getting cancer, that could detect it early, wouldn't you want to know that?
For those who have already been diagnosed with cancer, it is important that you ask your doctor to have a screening test performed of the tumor tissue as well, to determine if your cancer is associated with Lynch syndrome. It is recommended by the National Comprehensive Cancer Network that all colorectal and endometrial cancer tumors be tested for a biomarker known as MSI-high. Access Health caught up with Dr. Heather Tomlinson, Director of Clinical Diagnostics at Promega. Their research and development team has pioneered MSI testing.
Understanding biomarkers within tumors can give us helpful information on how to best treat that particular tumor. Microsatellite instability high, or MSI high, is a biomarker commonly associated with Lynch syndrome. When a tumor is known to be MSI high, it's essentially missing the spell check on the DNA. That's in contrast to tumors that behave more like normal cells. Those are called microsatellite stable. If a tumor is MSI high, we can then do further testing to determine if it is Lynch associated. It's important to note that not all tumors that are MSI high are associated with Lynch syndrome, and that's why further testing is needed. When we know a tumor is MSI high, it can help guide treatment decisions, and it also enables treatment based on that biomarker specifically and not necessarily where the tumor originated in the body, possibly treating the tumor more effectively.
So I feel like Jacqueline's death was caused by the perfect storm. We didn't know Lynch syndrome was in our family's genes. Her doctor had never heard of Lynch syndrome, and her doctor thought she was too young to get colorectal cancer. Had any one of those three things been different, she'd still be here today. So knowing you have Lynch syndrome is really important. And the benefits of knowing is that it's life-saving, it's powerful, and it gives you the power to change your genetic destiny instead of leaving it up to fate.
I feel like much hope is on the horizon for people with Lynch syndrome. You can take advantage of both preventive strategies as well as early detection if you know you're a carrier. Right now, we have the first ever clinical trial for a vaccine for Lynch syndrome ongoing in the US. That's for healthy people who are Lynch syndrome carriers. So if you don't know that your tumor is MSI high, you can't take advantage of some of these newer treatment strategies.
I'd like to thank Joan for sharing such a personal story with us today. For more information on Lynch syndrome, visit jrushfoundation.org, and for more on the MSI testing discussed here today, go to promega.com.
For more information on clinical trials and any of the subjects we've covered today, you can visit our website, accesshealth.tv. See you next time.